So I usually finish all my lectures after an hour and a half. Okay, so let's try to start now. Okay. Hi guys, are you seeing this? Can you please reply because I cannot check on everyone.
Yes, ma'am.
All right, so we will start. Okay, so for our online classes, I have several rules that is very peculiar, no, to me during our classes. So first and foremost, please mute your mic while the lecture is ongoing, unless there is a question being asked, then you may unmute yourself and ask the questions. Or if you are shy, you can just type your question in the chat box and we'll answer it after the lecture itself. Okay? I encourage asking questions because in neuro, asking questions makes really good synaptic transmission and it encourages more retention, no, of our learning material. Okay? So if you can keep your video as open as much as possible for this to promote our interaction. It will also keep you awake and give your full attention and focus. Okay? So if you have to go out and go to the bathroom or drink something, you may mute yourself or cover your video or close your video temporarily. Okay. So for me, I am very particular, because we want you guys to learn as much as possible. I have very short quizzes after the lecture, and there is an extension period for you to submit these requirements up to 12 midnight tonight. So I'm going to give you free 30 minutes, no question and answer after the lecture, and you may answer the assignment provided. Or you may answer it later but submit not later than 12 midnight. Okay? All right, let's begin. So our lecture is about cerebrospinal fluid. I am Dr. Arian Valerio. Okay, so I am from St. Louis University and I am a trained adult neurologist. Okay. All right. Okay. There are more students coming in. Glad to see you all. Okay. So let's proceed. Okay. So our learning objectives for this afternoon is to review the functions and basic physiology of your CSF. That includes your formation, your circulation, and even the absorption. And we will also discuss disturbances in your CSF pressure, volume, and circulation. All right? So we will discuss very common CSF pathologies later on. So, okay, I love doing a question and answer during my lecture. So, if you want to answer, you can unmute yourself and provide the answer. No, it would be very, very nice if you interact and participate. Okay, so let's start with this one. So, the CSF plays which of the following roles? So, one, it provides protection from mechanical trauma, it provides buoyancy, it maintains homeostasis. Is it A and B only or all of the above? What do you think, guys?
All of the
All
above.
of the above.
All right, very good. So it's all of the above. Okay, so the functions of your CSF is primarily for mechanical protection. Okay, so it absorbs, it's a shock absorber for all the trauma, during movement of the head. It also provides buoyancy, meaning it allows your brain to float in water. So your brain usually weighs about 1.2 to 1.4 kilograms, no? But with buoyancy, with the CSF, it only weighs up to 50 milligrams, no? So that's a large discrepancy, no? It provides what do you call this, a safe movement, no? Every time we move our head sideways or forward and back. Okay, it also provides what we call the sink action, where it removes all the waste products of your cerebral metabolism. So the brain and spinal cord do not have lymphatic system. So it is the function of our CSF to provide this function. So it removes mainly carbon dioxide, lactate, and hydrogen ions. By doing so, it maintains homeostasis. Okay, so it maintains a relatively constant volume pressure relationship with all the other parts of the CSF. Okay, so another question up here. During lumbar puncture, for example, you collect 50 ml of your CSF sample. How many hours will you expect the same volume to be replaced? Okay, this is a very technical question, but it would be fun for you guys to just pick. Try to make an educated guess. What do you think? 30 minutes, 2 hours, 8 hours, 24 hours, or 48 hours? What's your pick, guys? Wala nagaan.
B.
Okay, so people are answering, ano? Alright. I can see your answers there. So the answer is, I'll give it later. Okay. So this slide is what is important, no, in your CSF formation. So there's about 21 to 22 ml per hour. Okay, so that is what is formed. So in a total, there's about 500 ml per day. That means that mga running, no, 100 to 150 ml lang kasi ang CSF. So it means that there's 4 to 5 exchanges of your CSF, no, from formation to absorption, and then it is renewed again for about 4 to 5 times per day. So the answer here is B, 2 hours. Okay. So for our CSF formation, the main organ no, responsible is your choroid plexus. Okay, so look at this picture. These are your ventricles lined with these tuft of blood vessels that is covered by a very thin layer of epithelial cells, no, projecting inside the ventricle. And in your left side or right side rather is your brain parenchyma. Okay, left side is your ventricular surface. Okay, it almost looks like your glomerulus in the kidney. Okay, so the location of these choroid plexi will be in the floor of your lateral, third, and fourth ventricle. So these are the main sites of your CSF formation. Later on, we will study all of this. Okay. So your choroid plexus forms your CSF through two functions, your passive diffusion and active transport. Okay, so look at this picture. So these are your ependymal cells. Okay, so in the left part is your blood, no, or your plasma, and on the right region is your CSF towards the ventricle. So A is a very good example of your passive diffusion. So all the solutes just passively goes through the cells into your ventricular region, no, and water just follows. That is your passive diffusion. This accounts for minor volumes of your CSF. Okay. Largely, the volume of your CSF is dependent on your active transport and facilitated diffusion. So for active transport, there is a need, no, for the use of your energy in the form of your ATP. All right. So in the apical surface of your ependymal cells, there are what we call pumps. Okay, these are powered by your ATP, such that we call it your sodium potassium ATPase pumps, which pumps mostly sodium into the ventricular surface, no, pulling out all the water and other solutes with it. Okay. Also important to note, okay, that inside your ependymal cells, we have a process going on which converts your water and carbon dioxide into hydrogen ions and bicarbonate. This is the function of Ca, or what you call your carbonic anhydrase. So please remember this because this is very important in the management of diseases of your CSF. Okay? So because of this, no, the hydrogen ions are pumped out and bicarbonate is used towards your apical surface in the ventricles. Okay, this pulls water again, no, to create your CSF. Okay, so we have sodium potassium ATPase pump, we have potassium chloride pumps, we have transport for your bicarbonate, and we also have sodium, chloride, and potassium pump in your apical surfaces. All right, so that's what's important. And lastly, we have your facilitated diffusion, which uses specific channels. No, in this picture, the one that's exampled or shown is your aquaporine 1 channels. This aquaporine channels is responsible for the movement or facility of your water to move towards the apical membrane into your CSF. Okay, so far so good, guys. Okay, just type in your questions if you have, and then you can unmute yourself if you want to ask your question live. Okay? Or we can answer it later after the lecture. Okay, so because of that process, our CSF is very much comparable to our serum. So I have highlighted several differences which are very important in the interpretation later of pathologies. Okay, important to note that the osmolarity and sodium of our CSF and serum are almost the same. No? There's very, very minimal changes. However, for your potassium, CSF has smaller amounts, no, compared to your serum. Right? So also with regards to your carbon dioxide tension, there's more carbon dioxide and more carbon dioxide in your cerebrospinal fluid, and this is responsible for the slight acidity of our CSF compared to your serum. Another important information regarding this table is the amount of ammonia. Okay, so in our serum, there's as much as 70 grams per deciliter, but in the CSF, it's only 30. Okay, this is why when there is an overproduction or there's a high volume of ammonia in the bloodstream, it is very toxic to the brain because it cannot process too much ammonia. It can only handle a very limited amount. Okay, and then lastly, our glucose, which in this table is shown as two-thirds of serum concentration. Okay, so far so good. So those are the important ones, no? So osmolarity, sodium, potassium, carbon dioxide tension, pH, ammonia, and your glucose. All right. Now we go on to your blood-brain barrier. So the blood-brain barrier, or BBB as we call it, is the interface between our blood and the CNS components and CSF. So this one acts as a filter, no? So that not all the nutrients come inside or within the CSF. So it maintains the equilibrium between our CSF and plasma, and it is a filter for toxins and particularly drugs. Okay? So the components of our blood-brain barrier, as seen in this picture, is mostly composed of your endothelial cells, okay, which includes your tight junctions, because it means there are no spaces. No? In the systemic circulation, in the capillaries, there are fenestrations in the capillaries. However, capillaries in the brain do not have these fenestrations. Instead, they have tight junctions. Okay? So this will not allow passage of your toxins from the blood into the CNS and CSF altogether. Okay, next is we have the plasma membrane here, very thick basement membrane of your endothelial cells, even your adventitia, and lastly, the pericapillary foot processes or the podocytes of your astrocytes. Astrocytes are supporting cells in the central and peripheral nervous systems. Okay? So those are the three components you must remember. Okay? So now that we've mentioned your blood-brain barrier, so we mean to say that the entire CNS has this blood-brain barrier, except in certain regions. So there are certain regions which we call your circumventricular organs, okay, that do not have your blood-brain barrier. This is seen in this picture. We have here towards your brain stem, towards the back or the nape area is your area prostrema. Okay, your subcommissural organ here, pineal gland, subfernical organ, vascular organ of the lamina terminalis, the median eminence, and the posterior pituitary region. So these are the 7 ones. Okay, so we call them all together your circumventricular organs. These regions do not have your blood-brain barrier for two reasons, okay? For the for ease of release of your hormones, particularly in your pituitary gland. And number two, these act as checkpoints, no? So they are sensory points to know if there are toxins circulating in the central nervous system. Okay, that's why if there are toxins, no, your area postrema picks it up and you will have vomiting. Okay, so that's why when you eat something toxic or you smell something toxic, no, there is vomiting because of the area postrema that is responsible for that reflex, vomiting reflex. It does not have your blood-brain barrier and easily picks up the sense of toxins. Okay? All right. Okay, third question. So, which region of the ventricular system provides the bulk of the CSF volume? Okay, so sorry. So, A, is it your lateral ventricle? B, your third ventricle? C, aqueduct of Sylvius? D, fourth ventricle or arachnoid villi? Okay, as you see in this picture, we are showing you the ventricles. So this is your lateral, your third, your aqueduct of Sylvius, fourth, and the arachnoid villi are not seen in the picture. Okay, so what is your answer? It's most of your answers. Okay, so, okay, very good. All right. So majority answered letter A. Right?
Doc,
Yes.
baka hindi na po makapasok ng iba naming classmates.
Oh, okay. Sige. Am I seeing them? Sige. How many are you in the class?
Doc, 114 po.
Wow, ang dami. Do they still have the link? Kasi parang 100 participants lang ata ang Google Meet, ano?
Yes po, Doc.
Sige, please get their names kung hindi sila makapasok sa um, sa ating class. I will do something for them later kasi we can do a makeup class for them or I include them in the next class for the same lecture. Okay?
Okay po, Doc.
Okay, please get their names na for me. Thank you. All right, so let's proceed. So CSF circulation. So the principal site of formation of your CSF is the choroid plexus of the lateral ventricle. So remember your choroid plexus are like glomeruli protruding in your ventricles. Okay, so other sites would be your third ventricle, fourth ventricle, and it also includes perimedullary and perispinal subarachnoid spaces, even the cisterns, and up to your superior and lateral surfaces of the cerebral hemisphere. So this is actually the pathway for your CSF. Okay? So let's go on about this picture and let's try to trace your CSF flow. Okay, so the primary site, we have a left and a right lateral ventricle. So this is highlighted in red. Okay, so this is the left side. And then from there, it passes through your foramen of Monroe to go into your third ventricle. So you see the relationship, your lateral ventricle follows the contour of your hemispheres. So the lateral ventricle lies between your hemispheres, both the left and the right hemispheres. And then it goes to your third. So notice the anatomic location of your third ventricle. It is within your diencephalon. So it is one chamber only, sandwiched between your thalami and the rest of the basal ganglia. Right? So from your third ventricle, you have your aqueduct of Sylvius going to your fourth ventricle, which now lies in your brainstem and pontocerebellar junctions. And from there, CSF exits through two other foramina. Laterally is your foramen of Luschka, so L lateral. There's two lateral foramina and a medial foramina, which is your foramen of Magendie, so M medial. Okay? So from there, it goes into your subarachnoid spaces It fills up your basal and ambient cisterns, which I will show you in another picture later. And then it flows through your entire lateral and superior surface of the cerebral hemispheres. So this is basically the summary of your CSF outflow. Okay, so this is the outflow tract. All right. So in this picture, no, we see these are the cisterns that I was telling you about. So there's a prepontine cistern here. There's a cisterna magna over there. So here are more cisterns. These are smaller regions than your ventricles that have CSF collection. Okay, so from the lateral ventricle to the third, down your aqueduct of Sylvius, to your fourth ventricle, going out into the Magendie and Luschka to your subarachnoid spaces. Subarachnoid spaces envelope your entire brain and spinal cord, no? To the cisterns, no? And then to the surfaces of your hemispheres and back to the circulation through your arachnoid villi. Okay? So your CSF circulation is driven by several factors. The first one is what we call drift. So there are certain pressure differences within the compartments of your CSF. So the highest pressure will be in your ventricles, specifically your your lateral third and fourth, and then it diminishes successively along your subarachnoid pathways. Okay, there are also oscillations that are provided by the hair-like projections within your ependymal cells in the ventricle. Okay, your choroid plexus will also have arterial pulsations that tend to push the flow of your CSF from the ventricles towards your subarachnoid pressure. And lastly, we have your transmantle pressure, which is the pressure gradient between the brain parenchyma itself and the ventricles. No? So it means that there is higher pressure in the brain tissue itself versus the ventricles, and this avoids the backflow of your CSF towards the brain parenchyma. Okay? We now go to your CSF absorption. So we've now seen the formation, the outflow tract, and we now go to your CSF absorption. So your CSF absorption is largely the responsibility of your arachnoid villi or pachyonian granulations as we call it. So in a side view or sagittal cut, no, we can see these are projections by your arachnoid matter, no, going through your sagittal sinus, which are veins inside the cranial vault. So in a cranial view, no, these are your this is your right and left hemisphere, no, of the frontal region. This is your falx cerebri. This is your arachnoid membrane. So we see that your arachnoid membrane, this mesh-like spider web, no, region, has several tree-like projections that go into your sinuses or venous collections within the cranial vault. So from here, the CSF flows, no, and then it gets filtered out back into the venous region and back into the entire circulation. Okay? So the arachnoid villi or pachyonian granulations, no, are the ones responsible for your CSF absorption. Okay? All right. We go now to your CSF fluid volume and pressure when during your recumbent position. Yes, it is 8 millimeters mercury or about 10 centimeters water. So as you try to sit up or stand, the pressure drops, no, even to as low as 0. So there are several factors that provide this pressure and flow. Minimally, it is affected by your systemic arterial pressure, but largely, no, and more immediately, it is affected by your venous pressure, as evidenced by its relationship with your CSF absorption and the arachnoid villi. Right? Any questions so far, guys? Okay. So this means that certain functions, particularly your Valsalva maneuver, when you try to give or try to hold your breath, okay, that's an example of your Valsalva maneuver, or when you are straining when you're in the bathroom, okay, this increases your intrathoracic pressure, and thereby it increases the pressure likewise in your large veins, in the vena cava, that such that there is resistance in your venous pressure in the venous sinuses, no? And it immediately raises your intracranial pressure. So venous pressure is much more important in maintaining the pressure and volume of our CSF versus your arterial pressure. All right? Okay. Another one that is responsible for our CSF volume and pressure is the level of carbon dioxide. Earlier in the slide, I've shown you the difference between the serum and CSF carbon dioxide tension levels. Okay? So it is a little bit higher in the CSF, which actually produces a slight acidification of your CSF compared to your serum. Okay? So remember that higher levels of your carbon dioxide will intensify your acidification, and acidification causes cerebral vasodilation. So remember that one of the waste products of our central nervous system is your hydrogen ions. Hydrogen is responsible for your pH, or the acidity or alkalinity of a particular volume of the CSF. Okay? So, if there's a lot of these metabolic waste products, our CNS blood vessels will tend to vasodilate in order to get rid of this waste product. Okay? So there is compensatory cerebral vasodilation, and as a result, cerebral blood flow will now increase, and cerebral blood volume will also increase, leading to an increase in pressure in the intracranial vault. Okay? So remember, if you try to increase your CO2 further, the pressure within the intracranial vault increases further. And this is the pathogenesis behind that. Okay, so why is this important? There is such a term as hyperventilation, okay, wherein we blow off excess carbon dioxide. Okay, so as we try to decrease the serum PCO2, we also decrease the CSF PCO2. This gradually raises the pH and becomes alkaline. So when the CSF is more alkaline, there is instead vasoconstriction. So there will be a decrease in cerebral blood flow, and therefore it reduces CSF pressure. Now, this is important for us clinicians later on, because in the event of an acutely raised intracranial pressure, for example, the patient comes into you for a severe, very, very bad stroke in the ER, okay? So GC is 13, after 30 minutes becomes GCS 6, you do your neuro-PE and you notice that there are symptoms or signs of increased intracranial pressure. So for these patients, kunyari, you don't have IV fluids yet, you're still trying to do all these things. So the quickest way you can do is actually put an ambu bag and hyperventilate the patient. That will give you ample time in order to institute your decompressive measures. So you can manage your ICP shortly, but never for longer than 30 minutes to 2 hours, because it will lead to severe vasoconstriction and you may have infarctions as a side effect. Okay? So this is very important. All right? Now we go to your intracranial pressure and volume. Okay? So imagine this diagram, So this brown is your cranial vault, no? The cranium, an inelastic cranium, including its meninges, and the component parts within it are your brain, your CSF, and your blood, which is divided into your venous and arterial. So these are the normal volumes for the component parts of your intracranial vault. So the brain ranges to about 1,200 to 1,400 ml. Your CSF ranges from 70 to 160 ml. And the blood, both arterial and venous, is about 150. With these normal volumes, your average intracranial volume is about mga 1,700 ml. Given this average volume, your ICP is within the normal range of 10 to 18 centimeters water. Okay? So now we'll go to this pathologic condition. So what do you notice here? No? So compare it with the normal on the left side. Your pathologic diagram on the right side, no, shows us a brain volume of 1,400 ml, still normal. But now take a look at your CSF. It is twice the normal volume of 300 ml. Okay, because of this sudden increase in your CSF, there's a shift or a decrease in the component volumes of your blood. So it is decreased to 100 ml. So the first one to compensate is usually your venous blood, then your arterial, and then your brain. Okay? So with this increase in one of the component parts, no, there is a gross increase in your intracranial volume to 1,800 ml. So compared to the normal, it's just 100 ml greater. Not much difference. But because of the acute change, your ICP now increased suddenly to up to 25 centimeters water. Okay, so this is the basis for your Monroe-Kelly doctrine. It gives us the statement that you have a very rigid container, no, given by your cranium and your inelastic dura, such that any increase in the volume of its three component parts, no, your brain, your blood, and your CSF will now elevate your ICP. In the example provided earlier, an increase in the volume of one of the other three components will now be at the expense of the other two. So it means that if one of the volumes change, no, the other two will try to compensate in order to maintain a normal pressure. Okay? So under your Monroe-Kelly doctrine, we have several principles. We have compliance and elastance. So we'll take up compliance first. So compliance is simply put as the change in volume. So volume meaning yung volume of your brain, individual volume of your CSF, and the volume of your blood. No? So it is the change in volume for a given change in pressure. So it represents the accommodative potential of your intracranial space. Okay? Meanwhile, your elastance is its inverse. It is now the change in pressure observed for a given change in volume. And this is important because it is clinically measured. This is what we use, no, in the clinics. We can put a gadget inside your intracranial vault and we can measure the pressure because we can never really measure volume kasi in the brain, no? It's hard to weigh your brain, it's hard to weigh your blood, no? It's hard to get the volumes of these individual components in the intracranial vault. Okay? Okay. So I'm still accepting people pala. Okay? So compliance, elastance is the one that we clinically measure and it is the resistance to outward expansion of an intracranial mass. Okay, so looking at this pressure volume curve, you may find this curve in your physiology book in Guyton. No? So let's start. Okay, so in the x-axis, we see the change in volume of the components of your intracranial vault. And in the y-axis, we see the change in pressure. Okay, so we'll give you an example. So we have a 35-year-old male. Okay, let's do a 65. We have a 65-year-old male. This male is hypertensive. No, let's say he had a stroke, a hemorrhagic stroke. All right. So the start of the stroke was at 4 o'clock p.m. No, and because the blood pressure was uncontrolled, at 6 p.m. the patient started to complain of vomiting, headaches. Okay. So initially, the volume of your hemorrhage is about mga 20 ml. After 2 hours, it becomes 100 ml. Okay, so let's start with 20 ml initially. So from a zero change in your volume, this patient at 2 hours had 20 ml additional blood from hemorrhage, no? So there is very, very little increase in your pressure. It is maintained at 10 millimeters mercury at an increase of 20 ml. Okay? So at this point, there is very high compliance. No? The intracranial contents can still compensate for that very small amount of additional volume. So let's say this patient was still not seen by the clinician, still not treated, and after another hour, from 20 ml of hemorrhage, it now becomes about 80 ml. Okay? So at this point, there is a very large increase or expansion of volume within the intracranial vault up to 80 ml. So that's additional. In here, you will now see a gradual shift and gradual increase in your intracranial pressure. No? It is between 10 and 20. So mga between 15 and 18 at 80. Okay? So between 15 and 18 millimeters mercury at the 80 ml volume increase. Now, let's say this patient is still untreated and given another hour, the total hemorrhagic volume has now increased up to 110 ml. At 110 ml, all the components of your intracranial vault loses their compensatory mechanisms and are unable to bring down the pressure as close to normal. And there will be a very steep increase in your intracranial pressure. So at this point, there will be no more compliance from your intracranial vault. They cannot change their volume anymore to accommodate the pressure. So this is the danger zone. This is where our herniations occur. Okay, so this is the danger zone. So you see the changes in the volume, no? Initially, at very, very small volumes, there is very little change in pressure. And as you go higher up in your volume, no, there will be a very steep increase in pressure. Okay? All right. So we now use all these data to clinically correlate. So neurodiagnostics first. So we use our CSF for several studies. No, this is what we call our lumbar puncture or CSF analysis, where we study the pressures, the appearance and volume of our CSF, and even the cell counts, including your WBC and RBCs. Okay, so lumbar puncture and CSF study is done to obtain pressure. And to procure a sample of the CSF for analysis, we can also use it to administer anesthetics and other medications, and sometimes to aid in diagnostic studies by injecting a radio-opaque substance. But we rarely do this, no, because it is very risky. It entails high risks to the patient. Right? So in doing a lumbar puncture, there are several risks, no? Especially if the intracranial pressure is high. So we have very benign ones and we have very toxic ones. The most toxic is what we call your herniation. So herniation is displacement of your intracranial components from an area of from an area of greater resistance to an area of lesser resistance. So it will try to move from its original position to several areas like your foramina. Okay, so your foramen of magnum. No? Okay, foramen magnum. So herniation is higher in patients who have focal mass lesions, no? If they have abscesses or tumors or strokes in the area, and even in patients with very high pressures. So these patients are in need of neuroimaging. No, you can use your CT scan or MRI prior to lumbar puncture and medical decompression using mannitol. We may use other medications such as hypertonic lactate or hypertonic saline. Okay, and it is also higher in patients who have spinal block. Okay, so in some cases, there are tumors in your spinal canal that actually raise the intracranial pressure, no, despite not having any lesions in the brain, but instead lower. Okay? In some patients, there may be headache and vomiting after sudden change in pressure from the lumbar puncture. So we only address this, no? We address it by proper positioning and adequate hydration. There may be bleeding and infection such that we need to check their bleeding parameters before performing a lumbar puncture, and we have to perform it using sterile technique. Okay? So this is our lumbar puncture. We can either do it sitting or lying. We only do sitting position if the patient is very cooperative and awake. For patients with meningitis who cannot cooperate, who are very distraught, no, or delirious patients, we allow them to lie on their side, no, parang C position. Okay, and we target the lumbar region. Okay, so why do we target the lumbar region? It's because your spinal cord in the adult ends at L1 to L2 vertebral interspace, okay, such that anything below it is safe, no? So we may avoid puncturing the spinal cord. So we do the lumbar puncture in the L3, L4 interspace or L5, L4. So these are the layers that we traverse during lumbar puncture. We have your skin, subcutaneous layer. We have your back muscles. We have your very, very thick supraspinous ligament. In some instances, we puncture your interspinous ligament and your ligamentum flavum. Okay? So what we try to access for lumbar puncture is your subarachnoid space because that is where your CSF lies. But for medications, we may be able to access your epidural space or your subarachnoid space as well. So remember the difference, no? For lumbar puncture, for CSF analysis, we try to reach, we have to be in the subarachnoid space. For medication or installation of anesthetics, we may access the subarachnoid space or epidural space. Okay? There is no CSF in your epidural region or epidural space. Alright. So in analyzing your CSF, first your appearance, it should be clear, water-like, colorless, no, not cloudy. Your cells may contain WBCs up to 5 per cubic millimeter, and largely it is composed of your lymphocytes and mononuclear cells. No? Normally, predominantly lymphocytes. Okay? Protein is about 45 to 50 milligrams per deciliter or less, and less than 20 in children. Glucose is about 60% of your serum concentration. Normal values are between 45 to 80. So you have to compare your serum glucose with your CSF glucose. That's why in lumbar puncture, no, you have to take your CBG or your RBS 1 to 2 hours prior or after your lumbar puncture. Okay, so pressure, we've mentioned this earlier in adults. It is 10 to 18 centimeters water or 8 to 14 millimeters mercury. Once it is beyond 20 centimeters water, it is increased intracranial pressure or intracranial hypertension. Once it is less than 5, it is now hypotension. So please remember these values. Greater than 20 and lesser than 5. Okay? Okay. So a little break. We have a question and answer portion again. So which of the following findings signify increased intracranial pressure? So A, we have headache. B, decreased cerebral blood flow. C, papil edema and blurring of vision. D, displacement of brain tissue. Or E, all of the above. So again, try to make a guess even if we have not yet discussed everything. So what is your answer? E. So majority is answering E. I can see your answers. No? Very good. All right. So let's go and discuss each one. So the clinical features of your raised ICP are as follows, no? Headache, nausea and vomiting, drowsiness or sleepiness, ocular palsies or papil edema. So I will mention this later. Head enlargement in children where sutures have not yet fused, and in severe cases, herniation and displacement of brain tissue that may lead to your brainstem compression and failure, which may lead to your brain death. Okay? So remember earlier I mentioned that there is an area without your blood-brain barrier in your area postrema. So likewise in that area, no, it is easily picked up if there is changes in pressure. There are changes in your pressure. Now, sudden change in your pressure, no, to very high levels will irritate that area, your area postrema, and will cause nausea and vomiting. Likewise, certain areas of your circumventricular organs, no, are very sensitive to these pressures and they activate pain-sensitive structures located in your dura and trigeminal-vascular system that may cause very severe headaches. Okay? Because of increased pressure, likewise, there is pressure within your cortex and your ascending reticular activating system responsible for your wakefulness. So when these areas are compressed because they are largely in your brainstem and diencephalon, no, you may experience changes in sensorium. Likewise, no, the increase in pressure may also have effects in your cranial nerves. Very sensitive are your cranial nerve 3, cranial nerve 4, and cranial nerve 6. That's why you have ocular palsies and papil edema because the pressure in the brain is transmitted in the optic nerve. So papil edema is the result of increased pressure in the subarachnoid space of your optic nerve. Okay? Because the subarachnoid space of the brain is contiguous or continuous to the optic nerve, the pressure is transmitted into the eye. This increase in pressure will now be seen clinically, no, as your papil edema or edema of the optic nerve, which we see in fundoscopy. Okay? So again, this diagram, you've seen this already. So the pathology, there is an increase in your CSF. So usually, the compensatory mechanisms in your intracranial vault is CSF first, and then your venous blood, arterial blood before the brain. Okay, it is but necessary to save or to make compensatory changes in the brain parenchyma last. Okay, because you want to always save the brain parenchyma from any damages. Okay? All right. So what causes this increase in intracranial pressure? So we have cerebral or extracerebral mass. So we have tumors, no? Tumors of the parenchyma itself, tumors of the meninges, tumors of the cranial vault itself. There may also be generalized brain swelling from infections like encephalitis, meningitis, and the like. People or patients with generalized epilepsy, especially if uncontrolled, may have secondary brain swelling as well and increased intracranial pressure. Okay? As mentioned earlier, any increase in your venous pressure will increase your ICP immediately. Because of this, there may also be an obstruction to your flow. So we've discussed the flow earlier, or any problems with your absorption in the arachnoid villi or your venous sinuses will also transmit and give you raised or increased intracranial pressure. So in other words, any process that expands the volume of your CSF, no, the production, no, such as in the case of your meningitis, which fills it with inflammatory cells, or subarachnoid hemorrhage, which fills the space for your CSF with blood, or any increase in your CSF production, like tumors, no, specifically problems in your choroid plexus, will give you an increase in intracranial pressure. So again, the answer to this question is all of the above. Okay? So we have headache. There may be compensatory decrease in blood flow. There is result of pupil edema and blurring of vision because of the optic nerve involvement, and there may be displacement of brain tissue if there is severe increase in intracranial pressure. Okay? All right. Okay, next question. The following is a condition where blockage of normal CSF circulation occurs, resulting in enlargement of the ventricles and increased intracranial pressure. So let's break down the question first. So what's important here is one, there's increased intracranial pressure. Number two keyword, there is blockage of CSF circulation. And number three, there is enlargement of the ventricles. Okay, so what is your guess? Is it hydrocephalus? Is it intracranial hypotension? Is it subarachnoid hemorrhage? Is it encephalopathy? Is it encephalitis? So what's your answer, guys? Okay, very good. Great job. So it's hydrocephalus. So hydrocephalus, we will discuss this. So this is a CT scan of a normal brain. So in a healthy, normal young adult, you may see that the brain is full and it is almost attached or touching the inner table of your cranial vault. Okay, so this is your normal outflow tract. In hydrocephalus, these are what we see in patients. No, there is an enlargement of your ventricles. This is a comparative CT scan. So you see that the parenchyma still touches the inner table of your cranial vault, but compared to the normal CT scan where the ventricles are slit-like, okay, here the ventricles are very, very enlarged. So we see CSF or water in CT scan as black. Okay, so in patients whose cranial sutures have not yet fused, the increase in intracranial pressure may push it outwards and they may have frontal bossing or head enlargement as well. Okay, so another comparative CT scan. So this is your normal frontal horns of the lateral ventricle. In hydrocephalus, this is how it looks like. No? So this is the frontal horn of your lateral ventricle, frontal horns here. This is your temporal horns of the lateral ventricle. And this is the third ventricle within the diencephalon. It's very, very big. Okay, and this is your fourth ventricle below your midbrain and some parts of your cerebellum here. Okay, so notice the difference. Okay, so hydrocephalus results from several mechanisms. So one, it could be an increase in production. So there may be tumors of the choroid plexus or there may be alterations in the physiologic production of your CSF. There may be problems or obstruction in your outflow tract, examples of which are aqueductal stenosis or lesions compressing the ventricles, such as a tumor, a stroke, or an abscess or whatnot, and decrease in absorption, exemplified by an increased venous resistance, no, or infections of your meninges and infection of your venous sinuses as well. Okay, infection or infarction, it can happen. Okay. So for hydrocephalus, there may be communicating or non-obstructive. So meaning there are no problems within the outflow tract. The problem is either production or absorption. Okay, this is exemplified by your meningitis, no, subarachnoid hemorrhage. These two pathologies expand your subarachnoid space and compress, no, the CSF volume. Another example is your venous sinus pathologies, no? Pwedeng infection, it can be infarction, no? Any compression of your venous sinuses can lead to problems in your absorptive capability, no? Which may give you communicating hydrocephalus and tumors, no? That increase CSF production but does not block the pathway. So, non-obstructive. The second type naman, on the other hand, is your non-communicating or obstructive hydrocephalus. So, the problem with the second type is an obstruction in your outflow tract. There may or may not be a problem in production or absorption. Okay? So, an example is your aqueduct stenosis or the narrowing of your aqueduct of Sylvius or any tumor or lesions blocking or compressing the pathway. So remember, the anatomic configuration of your ventricles. So your lateral ventricles are near your cerebral hemisphere. So there's a frontal horn, a temporal horn, an occipital horn. So any lesions in your frontal lobe, temporal, or occipital lobes may compress the lateral ventricle. On the other hand, your third ventricle is within the diencephalon. So components of your diencephalon include your hypothalamus, your thalamus largely. So any lesions in your thalamus may compress the third ventricle and may give you a non-communicating or obstructive hydrocephalus. Going further down, your fourth ventricle is near your pons and cerebellum. So any lesion in your pons, in your brainstem or cerebellum may compress the fourth ventricle and still give you a non-communicating hydrocephalus. Okay? So using this example again, no, just what I've mentioned, we have a frontal horn, a temporal horn of your lateral ventricle, and occipital horn. So yan is your lateral ventricle. Your third ventricle is between your diencephalon. Your fourth ventricle and aqueduct is within your brainstem and pontocerebellar cisterns. Pontocerebellar region, sorry. Such that I give you an example here. So we have a pathology which is narrowing of your aqueduct of Sylvius, no? So this aqueduct runs through your midbrain, pons towards your fourth ventricle. So if this is narrow, but the CSF production is normal within all the ventricles, what do you expect? So first and foremost, in the narrowing of your aqueduct of Sylvius is this communicating or non-communicating hydrocephalus. What is your answer? So is it communicating or non-communicating? Okay. Jezir said communicating. How about the others? Okay. All right. I'll show you this picture again. So, remember that in your non-communicating hydrocephalus, the primary pathology is a defect in your outflow tract. Okay? So one of the examples in a defect in your outflow tract is aqueductal stenosis. So technically, stenosis or narrowing of your aqueduct of Sylvius is a non-communicating or obstructive hydrocephalus. Okay? All right. Such that what happens to the other parts of the outflow tract? So we have here a very, very narrow, barely allowing CSF to pass, narrow aqueduct of Sylvius, but the rest of the outflow tract and circulation is normal. So what happens to the proximal parts? Proximal parts meaning the structures that happen before or the structures that exist before the obstruction. So these are your third ventricle, your foramen of Monro, and lateral ventricle. That is your proximal structures. Meanwhile, your distal structures are the ones that appear after the obstruction. So here is the obstruction. So the structures distal to the obstruction are your fourth ventricle, your foramen of Luschka and Magendie, and the rest. No? So in hydrocephalus obstructive, what happens to the proximal parts? So the proximal parts enlarge. Okay? Why? Because the CSF production in here is normal. So they keep producing, no? They keep producing CSF, but it never really passes through. So it accumulates in the proximal regions, meaning regions before the obstruction. So in this patient with aqueductal stenosis, you expect that the third and lateral ventricles will be large. Okay? Now, what happens to the distal structures? What do you think, guys? So, does it stay normal? Does it shrink? Does it become smaller? Or does it enlarge as well? So, what is your answer? What happens to the distal? What happens to the distal regions of your CSF outflow tract? All right. Okay. So it becomes normal. Okay, it is normal. So let's take a look. So aqueductal stenosis, the proximal parts before the obstruction are enlarged. But the distal parts, no, are actually normal. Why? Because the production here is normal and the outflow tract towards its absorption is normal. Okay, so they do not grow or accumulate in size. So remember this because it is a very peculiar finding in obstructive or non-communicating hydrocephalus. Are you okay so far, guys? Okay, I hope you're okay because we are down to an hour. Okay, we're nearing the end. All right, so what is the clinical presentation for patients with hydrocephalus? So for young patients within the period of infants or congenital period, no, their cranial bones do not fuse yet. So normally the fusion of your sutures, your cranial sutures, is completed by ages 3 to 5 years old. So these patients less than 3 years old may have head enlargement, separation of the cranial sutures, and enlargement of the enlargement of the head. As you've seen in the picture I shown earlier, no, this patient may have pinch face. Why? Because the head enlarges so much, but the face does not become altered in proportion. So the face looks smaller than the entire head. Another presentation is what you call your setting eye sign. So this is your setting eye sign. So look at this picture of this kid, no? So there's head enlargement, there's setting eye sign. So it looks like The eyes are that of sunset, no? Because in hydrocephalus, there's increased pressure, and this increased pressure compresses the tectum of your midbrain, which controls upward movement of the eyes. The upward movement of the eyes are suspended such that the patient almost always looks down as if looking like your setting sun. Okay? Patients may present with poor feeding, arrest in developmental milestones, and later, if it is not relieved, flexed arms or posturing and extended legs. And in some cases, there's bobblehead syndrome to try to relieve the pressure transiently. Okay, so remember this outflow trap. Causes could be intraventricular matrix hemorrhage, particularly in premature babies, no? Infections during the fetal and neonatal period, congenital problems like stenosis or atresia or total loss of your aqueduct of Sylvius, or conditions like your Dandy-Walker syndrome. Your Dandy-Walker malformation is a congenital problem, no, which results in a cystic cavity in your posterior component, no, and malformation of your cerebellar hemispheres. So they do not fuse, and there is absence of the midline portion of your cerebellum, such that in your CT scan, the posterior region looks as if it is filled with CSF. Okay? This is on MRI. No? Sa MRI, white. CSF appears white. So it appears cystic. Okay? So in older children, hydrocephalus may be occult. They may only be evident, no, after the sutures have fused. So there's no head enlargement, no setting eye sign, no pinched face. So in this patient, the more prominent symptoms are headache, vomiting, vision changes, ocular palsies, and change in sensorium, as I've mentioned earlier. There may also be regression in your developmental milestones. No? So these patients do not usually walk compared to their normal counterparts. There may be difficulty in processing, there may be change in behavior, and there may be presence of your pathologic reflexes beyond 1 year. So kahit mga 5 years old, 6 years old, they may still have the sucking, grasp, and extensor toe responses, which are pathological at that age. Okay, so for you guys, what is important is recognizing when there is an acute change in intracranial pressure provided by your hydrocephalus. So your patients would usually present with headache, vomiting, visual obscurations. Visual obscurations mean there is loss of vision or there is blurring of vision at the height, no, of your increased intracranial pressure. This is because of the pressure in your optic nerve. Okay? There may be bilateral abducens palsy and limited up gaze as seen in the setting eye sign. Patients may become drowsy or stuporous, no? Babinski may be present and there may be increased tone in the muscles. So what is more important for you to check are the pupillary changes. No? In these patients, they change from initially anisocoria or imbalance. So one is small, the other is big. Then they later become pinpoint or very, very small. And afterwards, they become fixed, dilated, and unreactive to light. At that point, it describes brainstem, successive brainstem region compression, and herniation. So in these patients, they may also show what we call a Cushing's triad, no? The Cushing's triad, presented by hypertension or elevated blood pressure. This is a compensatory mechanism to try to increase the blood flow to the brain. So hypertension accompanied by irregular breathing because of compression of your brainstem breathing centers and bradycardia, then these three are followed by your hypotension. So this, when you see all these changes, plus or minus posturing, you may now say that this patient is in a medical emergency for impending brainstem failure. Okay, so what can you do in these patients with impending brainstem failure? You can do hyperventilation, you can administer medical decompressives, or you may refer them to surgery for surgical decompression. Immediately, these patients, if not managed properly, they may lead to mortality. Okay? So another question. Patient comes in for a 3-day history of fever with headache, vomiting, neck pain. Okay. So 3-day fever, headache, vomiting, neck pain. Which of the following, even if we have not yet discussed it, would you think would signify a bacterial etiology? So you may guess, guys, what's your answer? A, is it RBCs of 10,000? B, predominantly lymphocytic WBCs. C, low glucose levels to 30% of serum levels. D, CSF pressure of 15. And E, protein level of 40. What's your answer, guys? Okay, sorry, I showed it na pala. Okay, thank you for participating. So the answer is low glucose. Why? Okay, so RBCs are not present in your CSF unless it is traumatic, but even the presence of RBCs will not signify an infection. No? If it is WBCs, then pwede, but RBCs, no. It is very non-specific and would not point to an infection right away. So, in the CSF, normally, the presence of WBCs are normal and predominantly lymphocytic, as I mentioned. So, pwedeng normal yung B. So, D, CSF pressure of 15 centimeters water may still be normal. Protein of 40 is normal. So, remember that glucose compared to your serum is about 60%. So, reduction to 30% is definitely abnormal. Okay? So this table shows us the characteristics of your CSF in differentiating meningitis etiologies as to bacterial, viral, tubercular, and such. Okay, so the first three are the ones that are more important. So for your bacterial infection, WBC is greatly increased, but it is usually neutrophilic in predominance. Okay, proteins is elevated and glucose is lowered because the bacterial metabolic processes usually take up glucose. Okay, for viral infections, WBC is only slightly elevated, predominantly lymphocytic. Okay, glucose is rarely touched, so normal, and proteins are elevated. So another very important etiology here in the country, in the Philippines, is TB. So you will see many of this in the clinics later on. So WBC is elevated, lymphocytic, comparable to your bacterial. Protein is very, very elevated, and glucose is very, very low, often less than 50. Okay, so that is the difference between bacterial, viral, and tubercular. Okay, so elevated RBCs are seen in subarachnoid hemorrhage or traumatic CSF or lumbar punctures. However, in subarachnoid taps or subarachnoid hemorrhage, I should say, RBCs are greater than 500, and even if you do serial examinations of your CSF, the RBCs will still be present at very high amounts compared to your traumatic tap. Okay? Okay, another question. So we have a 70-year-old male brought by his wife for consult due to symptoms of dementia, meaning there are cognitive disturbances associated with gait changes and urinary continence over a few months. So which condition is most likely? Is it A, Alzheimer's dementia, B, subdural hematoma, C, cerebral hemorrhage, D, normal pressure hydrocephalus, or E, aqueductal stenosis? You may click in or type your guesses now. Sige. So make a guess. Okay, so let me see your answers. Very good. Everybody is participating. Very, very nice participation in this class. Okay, so this is the case of that 70-year-old. No? This is an MRI showing us almost atrophic, okay, no? Almost atrophic brain parenchyma, but very, very minimal. No, there's no obstructions noted, no tumors noted, but there is enlargement of the entire CSF outflow tract. Okay? So the answer is D, normal pressure hydrocephalus. This is presented with a triad. So one, and the earliest symptoms is a progressive gait disorder. So because of the gradual increase in the pressure or gradual hydrocephalus that takes up over time, no, it compresses the mechanisms, no, in the frontal lobe that is responsible for gait. So the gait disturbance is the earliest, most pronounced symptom in these patients, followed by impaired mental function. No, these patients are usually frontal, apathetic, dull, withdrawn, and inattentive. So these patients are very slow to process, although they would answer you coherently. No, very, very slow to process. And later on, in very severe cases, because the sphincter centers in the paracentral lobule are affected, there is now sphincteric incontinence. Okay, so pathogenesis, no, they say that there is a pathology that precedes the hydrocephalus. It could be any infection. There may be mild congenital stenosis, no, mild congenital problems, or even head trauma that is very, very minimal, no, such that the brain is able to compensate, no, for the first few months or years, and later on, as it is not addressed, no, hydrocephalus develops. So in this, no, given in the name itself, there is compensated hydrocephalus such that if you do CSF studies and lumbar tap, the pressures are normal. So this means that production is still equal to the absorption, no, such that the pressures are normal. Okay, so lumalaki, the ventricles enlarge, but the pressures are maintained because it is very slow in onset. It develops over months to years. Okay, so the brain and the components are still able to compensate. How do we diagnose this? So lumbar puncture, we find normal pressure, normal cell study, normal counts, no? And then it is also therapeutic, no? Removal of your CSF decompresses the entire outflow tract such that there is some clinical improvement with the patient's gait and mentation. Additional diagnostics would be your CT or MRI, such as seen in this picture. Hmm? So there's enlargement. No, some of our clinicians would say the ventricles look round or hot dog, no, in appearance. So this is your lateral ventricles, no, frontal horn, temporal horn of the lateral ventricles. This is your third ventricle here, frontal horn, third ventricle here. Okay, treatment is a shunt, no? We can do a ventriculoperitoneal to your abdominal cavity and peritoneal cavity, ventriculoatrial to the heart, or ventriculopleural to the lungs. So the safest one is the ventriculoperitoneal. So usually in patients with an established cause such as a prior subarachnoid hemorrhage, tumor, or meningitis, no, if these are relieved, no, then the patients have the most improvement. Okay? Another condition is your cerebral venous obstruction. Remember that the venous sinuses is very important in the absorption or resorption of your CSF, such that increases in intracranial pressure may result to any problems like a thrombosis or infarction of your venous cavities or any tumor that compresses these venous channels. Okay. Last two cases, we have 24-year-old Lexi coming in for persistent headache, occasional blurring of vision at the height of the headache. Now, what did we call this one? This is your visual obscuration. So there's some blurring of vision at the height of increased intracranial pressure or headache, and you are now suspecting idiopathic intracranial hypertension. Which finding is most expected? Let's break down the question. So obviously, this patient has symptoms of increased intracranial pressure, no? That hence the term. Okay? So when we say idiopathic, there are no causes noted. So there may not be any problems like infection or mass lesions. Okay? So what is your expected finding? A, mass on the temporal region. B, CSF pleocytosis. When you say pleocytosis, elevation of your WBCs in the CSF with neutrophilic predominance. C, right-sided weakness, so focal deficit. Or D, hydrocephalus on CT scan. Or E, papilledema. What is your guess, guys? Okay. Great. Great job. Great job, guys. Doing great. Okay, so let's discuss this pathology. Idiopathic intracranial hypertension is also known as your pseudotumor cerebri because it acts as if there is an acute tumor or mass lesion that causes the increase in intracranial pressure. You have symptoms of headache, papilledema, but minimal or absent focal neurologic signs, and normal CSF cell counts, but elevated pressures. And there is absence of enlarged ventricles or any intracranial mass lesions. So remember this syndrome, okay? They are actually very common in the clinical practice. All right? Okay, so the answer here is E. Great job. Okay, so risk factors, they say that overweight um, women, no, of short stature, no, with menstrual irregularities, and those with OCPs are the ones that are most vulnerable into having pseudotumor cerebri. There is a pathology, the pathological theory in the pathogenesis of this pseudotumor cerebri is based on a problem with your resorption. So remember that if there is increased intrathoracic pressure, particularly in overweight with overweight patients, both men and women with short stature, no, this translates, no, parang Valsalva maneuver. This increases the pressure and resistance into your venous cavities, thus, no, increasing intracranial pressure. So overweight, short stature, both male or female. They just mentioned women with menstrual irregularities or use of OCPs because there is a theory that this problem with resistance in resorption has something to do with your hormonal imbalances, no? Particularly your estrogen. Okay? That's why it's more common in women than in men. Okay? So there's an obstruction in the outflow of your venous sinuses, no? This is where your Valsalva maneuver comes into play, and there is an impaired absorptive capacity of your arachnoid villi, no, probably secondary to a past infection, past subarachnoid hemorrhage, similar to your normal pressure hydrocephalus. And in women, there is some relationship with your estrogen hormones. Other possible causes of your pseudotumor cerebri are the following. No? Dami-dami. There's so much. But I would like to point out here, no, your medications. So patients who use tretinoin, no, are postulated to have higher resistance in your CSF resorption. Likewise, use of your medications tetracycline, minocycline, and doxycycline also gives out higher venous resistance to your serum, to your CSF resorption. Just like I've mentioned, no, estrogen is also a problem, no? Usually same pathogenesis, higher venous resistance, okay, to absorption. All right? So the most troublesome sequelae or problem or side effect of your pseudotumor cerebri is vision loss. So we have to relieve this in these patients right away. So we have to use symptomatic treatment, no, for your headache, lumbar puncture, and CSF drainage if it does not respond to medications. And of course, our medications and osmotic agents. We have mannitol, hypertonic saline, hypertonic lactate, and acetazolamide. So remember, in the pathophysiology or your CSF production physiology, remember this slide where I showed you carbonic anhydrase. So the mechanism of action of your acetazolamide is to inhibit your carbonic anhydrase, thereby lesser production of your bicarbonate, no, and lesser production of your CSF pull towards the ventricle. So it lessens CSF production by inhibiting carbonic anhydrase. Okay, so far so good. Treatment, no, in patients who are overweight, no, weight reduction, shunting in very refractory cases, corticosteroids for those with flagrant papil edema, and sometimes fenestration of the optic nerve sheath, no? Because we want to save vision in these patients and relief of venous obstruction if there is one. All right. Last case. Julie consults 3 months after post-CS delivery, no, with headache, usually in the morning. Upon standing up, affecting mostly the base, no, in the occiput and nape area, and headache is suddenly relieved by lying down with no other symptoms reported. So what is the likely pathology? So let's break this down. So your first clue here is that this patient underwent cesarean section. So what are the mechanisms in cesarean section? Diba? There is an invasive procedure wherein you administer medications via the lumbar area. Okay? Pwedeng subarachnoid space. Okay? And then the headache is prominent when standing up. Remember that your CSF drops to almost zero or very low when standing up, and it is relieved when lying down. CSF pressure increases when you're lying down. Okay, so what is your answer? Yay! Good job! Okay, so the answer is your CSF leak post-spinal anesthesia. Our last case is your intracranial hypotension, where there is low intracranial pressure due to leakage of CSF through the needle tract into the paravertebral muscles. The most prominent symptom is headache or cranial pain, usually in the base or even up to the neck and shoulder region. Okay? This is prominent when you are upright because the pressure drops immediately, and it is relieved when you are lying down because the pressure normalizes or increases a little bit. In these patients, there is very, very little focal neurologic deficits, no? Usually very mild abducens palsy. So remember that normal CSF pressure, no, when it is less than 6, so for this case, 0 to 6 centimeters water, is already hypotension. Please be mindful of the, what do you call this, the measure, no? Sometimes we put millimeters mercury, sometimes we use centimeters water. Okay? So please try to familiarize yourself with the metrics used. So centimeters water or millimeters mercury. Okay? So this is that patient. No, this is an MRI of the patient. So normally, your brain is buoyant, no, floating in the cranial vault. But take a look at this patient, no, because there is very little pressure. There's very low pressure in the intracranial vault. No, the brain sort of sags. No, it occupies majority of the posterior portion. No, as this patient is lying down, and there is much space in the frontal or caudal regions. Rostral regions. Okay, so this is very characteristic of your CSF hypotension, a seeming lag, okay, or sinking of your brain parenchyma. Okay, so management, you prevent this from happening by being careful during lumbar punctures. Use a small gauge needle, use an atraumatic needle, and you have to advise these patients to be flat on bed for at least 4 to 6 hours to allow for normalization and production again of your CSF, no, before they become upright. And we may also hydrate this patient, so plain NSS or plain LR. In very severe cases, we do a blood patch. So we take the patient's blood and inject it into the epidural space. Take note of this kasi in lumbar puncture, we puncture only the subarachnoid space for CSF collection and the epidural space for medications. In blood patch, we try to put it in the epidural space in order to seal, no, to create a fibrosis in the epidural region such that the CSF will not leak away. Okay? Okay. Summary, we're almost done. So CSF protects the brain. It provides mechanical protection, buoyancy, and maintains homeostasis, no, chemically and in regards to your volume and pressure. So production is mostly in the choroid plexus, primarily in the lateral ventricles, and in a little more, in lesser portions in your third and fourth ventricles. It is produced, or CSF is produced via your passive diffusion, active transport, or your water channels. And the flow occurs from a higher pressure gradient, usually from your ventricles, downwards to your cistern and subarachnoid spaces where there is lesser resistance. Resorption is the function of your arachnoid villi draining into your venous sinuses. Okay, so that is why important yung venous system natin in the intracranial vault. So pathologies presented are your hydrocephalus, no, increased intracranial pressure and low ICP. Remember that these pathologies rely, or the pathogenesis is because of either increased production, an outflow tract obstruction, or a decreased absorption. And in the case of low ICP, your CSF leak. Okay? So here are our references for today's lecture. If you have any questions, we are open. Okay. All right. So how are you guys? Is the lecture okay for you guys? Let's check if there are any questions. Sabi pala. Okay. Let's check. Any questions, guys? You may ask me personally, or you may now type in your chat box. I cannot see any questions naman. Okay. So for your classmates who were not able to join, just give me a list of their names. Maybe I did not pre-record this lecture kasi, but I have another upcoming lecture. I can do a special class for them, or I will just coordinate with them. Okay? So please, please, please give me their names or give me a contact number so I can coordinate. Okay, there's a question from Elijah. Elijah, Doc, in what cases were ventriculoatrial or ventriculopleural shunts preferred over ventriculoperitoneal shunts? Okay, so in my experience, we very, very rarely do ventriculoatrial and ventriculopleural shunts. This is because of the very high risk, no? Kasi heart, no? High chance of congestion or respiratory compromise. But in patients who have, I have one case no, who had an infection in the peritoneal cavity. So this patient was being treated for peritonitis, bacterial peritonitis. So we could not do a ventriculoperitoneal shunt. So instead, we had to do a ventriculoatrial shunt. This was done by a thoracocardiovascular surgeon. So it's very, very tedious. It's very, very difficult to do. Okay, very, very risky. Any other questions?